We're on week 8. It's getting close. It's almost the end. We have a exam on week 10. We just got over exam 2. Anybody who wants to go over that with me, let me know. One of the things is you are seeing zeros on any sort of assignment. Please go back and look at comments. There may be it's the wrong way of submitting or something's wrong with it. So as long as you submitted it, I'll work with you. But please check those things because I know some of you here don't have things like CJ Sims with grades, and I want to make sure that you get your due just because you've done the work. Okay. So week 8 is GIGU. Really interesting week, and actually I like this week. It's a lot of different things from the adult world. Remember, you have your clinical pediatric assessment due by Sunday. You send it in. I'm trying to read them quick and send them back. I can't get to all of them. So the first one's in, we'll get that review and that chance to correct it and put it back in. Know that also you do have that pediatric assignment exam. It's through the modules into Evolve. It's the first time grade. So be careful with that, okay? And it's 50 NCLEX questions. But next week there is no quiz. So that is the one saving grace, for this, that there's no more quizzes. You are done. We have one more exam, week 10, and your HESI. For the HESI, I do have a review. I do it the Saturday before HESI, and it is already in my YouTube channel. Very similar things. I go back and look at last quarter and the quarter before's different topics, concepts that were on the HESI, and I make sure I put it into this review. So it is an up-to-date, current topics. If you know this stuff, you'll do very well on the HESI. So you can attend it live on the Saturday before the HESI. That's end of week 10, beginning of week 11. Or you can start listening to that on my YouTube channel. And then just listen to the differences, when I do the new one.
Will there be different times to take the HESI, or they're all just going to be on our time?
HESIs are scheduled by your campus. I have nothing to do with when they give them because it
Okay.
has to do with when they have somebody's available to proctor and if they have rooms to proctor in. Usually, they try to keep it around the same time as your class. So the night class, usually it's like a 6 o'clock or a 5:30 type of exam for the night people. So you get out of work and get in. But I'm telling you, all campuses are different. So reach out to your dean, reach out to the campus, find out when your HESIs are. It hasn't been posted yet, but you usually can find it. When you go to Evolve, go to the HESI Next Gen section. It'll show you when the HESIs are posted, when you need to sign up. So that will be the first place you'll see it if you don't find out the campus, okay? All right, let's go ahead and let's go on with week 2. Week 8. We're going to be doing GIGU. I do it differently. I actually do GU before GI. I don't know. I just like GU better. But I think GI is more complicated. So let's do GU. Gastro, genital urinary system. All about your urine, your kidneys, your bladder, your ureters. Now, infections of the urinary tract system are the most common of all things. Think about potty training toddlers, girls wiping, back to front, just trying to get it done. Boys not circumcised, that white substance, that schmegma that builds up there is like a petri dish for bacteria. And that goes in to the bladder and create problems. So that is a problem if it is not cleaned as well as it should. Now, the thing with bladder infections, parents go in, they've got a child, they're showing all the symptoms, they get the antibiotics, and all of a sudden they feel better. And it's such a hassle to get the antibiotics in that they don't finish it. The problem with not finishing it is, remember, the urine is connected to kidneys, and the kidneys can be damaged if we're not completely taking care of those infections. So, nursing function, make sure that child finishes those antibiotics. Now, what would we teach parents? What would they look at? What would tell you they're having some sort of infection? Well, it doesn't always mean a fever. Urinary tracts are not like that. You may or may not. What you might see is things like being incontinence and they're toilet trained, or you can smell it. The urine doesn't smell right, or they're sitting there rubbing themselves down there, or they're, moving, or, they're running quickly, like that urgency, that frequency. That'll tell you telltale signs. It's better to catch them as they start than it is to wait until that infection starts to go up the ureters and into the kidneys, and now you're, with a polynephritis, and we don't want that. So, instruct parents, know what those infections are and to be aware of them. Increasing fluids is number one for preventing urinary tract infections. The second thing is those hygiene habits, especially girls, front to back, not back to front, and young boys that are not circumcised. Make sure they pull it back every day and clean it so you don't have an area for bacteria to form there. Another thing is adolescence. Now, I've had quite a few girls come in with urinary tract infections, and I get parents leave, go get a cup of coffee or something, and I walk in the room, and these young girls tell me, yeah, they are having sex, and they don't want to tell their mother, of course, and they're having urinary tract infections. But what can they do? One of the things with having sex, and we can tell adolescent girls, is to urinate as soon as the sex is done, as soon as the intercourse is done. And that can help decrease the incidence of urinary tract infections. So I can't even tell you how many times I've told some adolescent that. So, okay, we've got a urinary tract, we've got the frequency, the urgency, and all of that going on. So we need to do something. So we'll do a urine culture sensitivity, absolutely. And the way that we obtain that's going to be different on every age of child. Now, on a premature child, there's no tube small enough. Go into the, urethra, into the bladder. And you couldn't find it if you really wanted to. It's like tiny little nothing there. So we do a suprapubic aspiration. Right up the pubic bone, right above, we stick a needle in and we get a little bit of urine, and that's sent for a culture. Miss Kelly, could you come on camera, please? I know you got a baby, it's crying. Another thing is cutaneous kidney taps. What if you had a chronic kidney infection going on? You might want to do a kidney tap to see what's happening in the kidneys. Is it something that's there? Or is it stuff in the bladder that's, exudates, thing that's creating it? Do a bladder washout. Is it structural? Let's do an ultrasound. Now, the bladder is called a vesicle. Okay, so the bladder is a vesicle. And then you have ureter. So vesicle ureter, reflux is going on. Many children. So doing ultrasounds, voiding cystourethropographies will show you the structure. Are the sphincters working, or is urine going back up into the ureters from that vesicle, that bladder, and then going into the kidneys and creating damage there? You don't know. Now, the things that can happen externally. Phimosis. This is when the foreskin is so tight you can't pull it down. My grandson was that. And if anybody could pull back a foreskin, it would be me. And slowly I tried. And after a couple weeks, I said, Daniel, nope, ain't gonna happen. My daughter. And we took him in and he was circumcised because of phimosis. All right. And we didn't want him to get all those urinary tract infections. Sometimes balanitis is that the skin sometimes gets pushed down, sometimes it's there and it gets all inflamed, all that foreskin tissue, and it can actually stricture that paraphimosis can stricture into the penis and choke it. So there are some things that can happen. I've seen phimosis can't go down. I've seen it pulled down, balanitis and the infection. I've seen it where it's pulled and it's stuck and we can't pull it back up. So you don't ever do anything rough because you'll rip it. I mean, this penis on a little infant or a little male, we don't want to hurt it, okay? What do we do usually, like the one that's stuck? We'll put some cool water on it and shrink it and very slowly, or maybe we'll put some steroid cream on it and shrink it and pull it down. But there's different things that can be done, but it has to be taken care of quick, or there'll be some constriction of blood vessels. Hydrocele is water in the testicles, basically. They call it peritoneal fluid in the scrotum, and it creates a lot of pain and irritation. Um, Older men get it, and they all of a sudden they're incontinent, and they get checked because I never been incontinent in 80 years, and all of a sudden, well, it's probably a hydrocele, and they're given an infection. They'll give an injection of an antibiotics and a Rocephin, and usually that's about all they need. Now, children, sometimes it stays there. They're born and they got this fluid in there. And remember, the fluid can create irritation, scar tissue, and all of those sort of things. Now, usually it's absorbed. This fluid usually is absorbed wherever it's at. But what they're going to do with the hydrocele is they'll do surgery, they'll remove that fluid. But remember, their testicles is going to have an incision line on it. So this is be the one that you've got to be careful with this child with play. They can't like be straddling up and going on their bike. Their testicles will hit the seat. Anything that they put their leg over and hit their testicles, you got to be very careful with, okay? Whatever that is. And then you can't bathe for a couple of days, only to get that incision line clean and already, closed. You don't want any other fluid in there. So orchidism is when the testicles don't come down into the sac. First time you go to the doctor's office with a little brand new newborn baby boy, they're going to be testing a couple things, and one of it is to check the scrotum to make sure, do I have two testicles in there? Now, it's not uncommon to have one nut down, two nut down, but eventually they do come down. Now, sometimes they don't. Now, one of the things with the examination, cryptorchidism, got to think of a male. Male, when they're cold, their testicles shrink and suck up in. So now your testicles, you're not going to feel them no matter what you want, right? So how would you examine this child? In a warm room, because then they'll hang and then you'll get are they there or not? The real valid answer. Now, if we leave those things up inside the abdominal cavity, it's too hot and it will render them infertile. So getting them down into the sac within the first year of life is very, very important. Hypospadias, epispadias. Really weird thing. Now, do you see that penis? Do you see that incision line that goes from the tip all the way down into the testicles? What happens is the urethra, instead of coming out the tip of the penis, came out at the bottom. Yeah, that's hypospadias, ventral, but it also comes dorsal, epispadias. Now, in order to fix this, it's done in the first year of life before potty training. You must keep that foreskin. That's part of the plastic closure. So you can see they cut it down, fillet it open. That hole that didn't come to the tip of that penis, they create a cavity and then they put in a catheter, a small catheter in there that stays there for like the first 7 to 10 days. And then the surgeon will remove it when it's done, and they do really well. So, what do you see with a problem with a hypospadias? What if you were Jewish? You want to circumcise your baby, don't you? You can't, because they need this tissue to do the plastic closure. Epispadias is just like what I just said, but it's on the bottom side. Instead of the dorsal side, the ventral side, it's on the dorsal side. Know that there can be openings anywhere between anything inside the your genitals. I've actually seen, and it's mostly nurses that find out that there's stool coming out of vagina or urine coming out, an anus. And those are fistulas and openings of different things. It's as you're cleaning them and assessing them, you find it. It's something you don't look for normally. I mean, epispadias, hypospadias, yeah, that's obvious. But things like the extrophy of different connections and fistulas and whatnot. Now, let's keep going. Extrophy. What do you do? Now, there's a time where the bladder, instead of being born inside the abdominal cavity, is born outside. The abdominal cavity doesn't close, and the bladder is on top. Now, we can put that bladder inside, but it's going to take us to make sure we keep that bladder free of infection, keep it moist, right? So that eventually, when they're trying to open up the abdominal cavity, make room for the bladder, it doesn't get infected. So we want to make sure that trauma is good. Now, it's still going to have urine that normally. The bladder's still connected the way it should. It's still going to be urinating into the bladder, into the diaper. It's not a problem. The problem is for us until we can get that bladder inside, a good wound care. Keep the skin free from exudate. Get a nice, wet, sterile, normal saline dressing and put it on that bladder extrophy at birth. Keep it moist, keep it sterile. Now, renal biopsies are done. Sometimes it's for things like tumors, but sometimes it's due to there's this infection that's going on and we don't know what's happening and nothing's showing up on cultures. So let's go into the kidneys and let's take a little biopsy. Well, it's just NPO pre-op and then send them to the procedure. What they do is on the children, they'll take ultrasound. The child is on their tummy because your kidney's on your back. There's on the back, it's right there. That's why you have to protect your back because your kidneys can be hit hard. And we'll go into that too. But they take an ultrasound and they look, they find it, stick a needle in, get a little, and they don't need much. Now, newborns, because the kidneys are small, it's hard to find. They'll do a little incision, maybe a half an inch, and not huge, but they'll take a little bit of urine. And then what they'll do is they'll close it up. Or if they didn't have to open up with suture line, they're going to put pressure on it and make sure that it's not bleeding and it's not oozing. When they're done and they're satisfied, they put on a pressure dressing and on older kids, a sandbag. Now, that sandbag puts that like a finger on a thing that's bleeding, right? Nothing out of bed for 24 hours. Very similar to cardiac cath, right? Now, what are you going to watch for after procedure? You've stuck a needle into a kidney. You're going to monitor urine, right? Make sure your urine output's coming on. You're going to make sure abdominal discomfort, urine, blood going into the peritoneal cavity because of this hole from this procedure. Those are things are what you're going to be looking for. Okay? Abdominal pain, tenderness, and monitoring intake and output. As I said, we can have obstructive uropathy. As I said, bladder is called a vesicle. All right. And we know that this is a picture out of your book. We know that there's ureters that goes to the kidneys. We know that there can be kinks on one ureter, both ureters can be more than one kink. And then there could be problems with valves, these things. There's so many things that could occur that doesn't make the kidneys and the bladder, working the way it should. So let's go to one of the syndromes, one of the clinical conditions, nephrotic syndrome. And I'm going to say this very loud. This has nothing to do with renal failure. This is not renal failure. The kidneys are working. But you know what the kidneys say? It says protein, yuck, get out of here, I don't want you. And you urinate, urinate, urinate protein. Well, why is that a problem? Remember your blood, intravascular. Do you remember that there's protein in there or albumin in there? Do you know that if all that protein And that's where all the drugs hop onto the protein. And the rest that's there is all the free drug that gets to you and gives you your body what it needs. There's no more protein. Drugs are extremely dangerous to give. You got to be very, very, very careful with that. No albumin because you protein, albumin, same name. So you're peeing out all your albumin, all your protein, all the stuff in your blood, all the albumin, protein in your blood, you're urinating that out. Now, there becomes a change in osmotic pressure between your blood vasculature and interstitial. And all of a sudden, tissue, all the fluid goes out interstitially, and now you have generalized edema. So you can see, what does this child need? This child needs protein, right? In order to suck it back in order to get this fluid out in those times of really bad crises. Managing it day to day, because it's not you're going to cure it. This is something a child has, something they're going to have to live with. So if we don't have protein and we have all the fluid going interstitially and we're swollen with general edema, nursing care, salt restriction, fluid restriction. Now, how do you measure fluid? Adults, children, don't matter. Intake, output, daily weights, right? Especially daily weights with children because they fluctuate more than do adults, right? Another thing with this disease, they are immunosuppressed. They are a risk for infection. I've also found that their children, that their mouths, because of the amount of swelling that's going on, their gums and their tongue get swollen and they don't want to eat. Because I've always questioned why loss of appetite. And it has to do with they're chewing, they keep biting their tongue, you know, their jaws and their cheeks, and they're just tired of chewing, right? And it hurts, so they stop eating. Now, they do because of all this extra swelling and stuff. They're not going to be as active, etc. But of course, just adjust their activity. And then, of course, siblings, mothers, fathers have to understand that salt shakers can't be around, and you really have to monitor fluid on these children. They need to do weights every day, and they need to keep a good running track of that so that they can tell the doctor what's going on. So, what's our care? Well, we want to decrease the amount of protein that comes out. In acute stages, believe it or not, and it doesn't make sense, steroids is the answer. That is the what we give them in this crisis when they're really swollen and their body is, at that stage. Doesn't steroids usually make you retain fluids? But in this case, no, it doesn't. The other thing is with nephrotic syndrome, always be aware that they're immunosuppressed, prevent infections, wash hands, etc., of course. And then how do you manage anything with fluids? Adults, doesn't matter. Children, doesn't matter. Nursing priority is intake, output, daily weights. Now, acute glomerulonephritis is caused by a strep infection that was not treated completely. Have you heard that before? Isn't that also rheumatic fever? And isn't rheumatic fever where everything can come back that's damaged except for the heart valve damage? In acute glomerulonephritis, you're going to see it all turn around. Now, what would you look like? Glomerulonephritis, oliguria, you stop urinating. Well, fluid got to go somewhere. So you're swolled everywhere. You got edema. With extra fluid comes hypertension, of course. And then it's periorbital edema with glomerulonephritis. Now, because hypertension can get high, because of this edema, etc., and this is kidneys, you have to be really concerned with blood pressures and headaches, because headaches could be elevated blood pressures and it might need other treatment. They can have blood in their urine, and of course, they can have protein in their urine. It's just part of the glomerulonephritis. How do we treat it? Just like rheumatic fever, given high dose antibiotics, let's take care of that strep. Remember ASO titer, anti-streptolysin titer? That's the blood test that confirms strep is still in the body. It's one of the blood tests that you should know. Prognosis is good. Most of them do really well and they completely turn around. On occasion, children turn to chronic disease because it wasn't picked up quickly or it wasn't treated properly. So manage the swelling, daily weights, intake, output. You might do the abdominal girth depending on how old the child is. And then, of course, low sodium. Take that salt shaker away, fluid restrictions, and you always going to wash your hands, right? Wilms tumor is your kidney tumor, right? Biggest thing is do not touch that abdomen because it will spill out and it will metastasize. Renal failure, acute, something made your kidneys stop working. Chronic, something's wrong with the kidneys and they haven't worked for a while and they're progressively getting worse. So an acute renal failure, it's not common, but one of the things we're always worried about is children with dehydration. Children with dehydration is serious and it can cause renal failure. So if you ever want to work with children, one of the things, if they are dehydrated, it's knowing that, those major organs need that fluid going around and to get the fluid bolusing up quick, get it to that child so that we can reverse that dehydration quickly because they will end up in acute renal failure. The kidneys don't like not having that blood flow going around. Chronic renal failure can be due to many different things. It's just when 50% of the kidney's not working and it gets worse over time. They also call it uremia. It could be congenital problems, or it could be that reflux that kills the kidneys, okay? Hereditary that it came to them. It could be pyelonephritis. That's why we treat urinary tract infections and we do a catheter on a little newborn baby because we don't want to hurt their kidneys in chronic pyelonephritis and causing renal failure, right? And then what else causes renal failure? Well, what about just an anaphylactic reason? They took a drug with anaphylactic and it went to the kidneys and it hurt them. That you can't stop. Another thing is lupus. It attacks organs. It can attack your kidneys. So again, those are some causes. So in chronic renal failure, what are we managing with? Well, we want to have that child, number one, try to make them as normal as possible. The dialysis unit that I used to work at when I was doing clinicals at our area hospital, I walked into them with one of the nurses playing a guitar, one of the children playing guitar, another kid singing, another nurse singing, and they're just in the middle of dialysis. So you can make it a lot of fun and you can make it as normal as possible. Can you imagine having to go 3, 4 days a week, 4, 6 hours at a time for hemodialysis as an older child? That's a lot of time. So having nurses singing and doing things like that can make it less of a chore to be so sick, right? So make them normal. Another one, try to make the kidneys work as best they can. Erythropoietin is going to help with those red blood cell production and to give more red blood cells to the body because, chronic renal failure, they don't have red blood cells. They don't have erythropoietin. Therefore, their hemoglobin hematocrits are chronically low. Now, one of the ways that we can treat newborn infants, young little children, up to 1, maybe 2, is peritoneal dialysis for those children with kidney failure. One of the conditions is prune gut that causes renal failure. And that was a little boy that I met over when I was doing clinicals at a pediatric prescribed daycare. And they were on peritoneal dialysis. Now, why do they get this tube inserted into their abdomen, into the peritoneum, and then they put fluid in and then they take fluid out, and that's their kidney? Why don't they put them on hemodialysis? Well, that in and out of blood is way too much swirling going on, and it will go to the head, and it will create the child to get too much pressure, and it can cause bleeds into their ventricles. And you know something? Children have enough going on for themselves. We don't need to create more. So we do peritoneal dialysis. Now, what happens is every time you do anything, attach anything to that tube for the dialysis, it's always in sterile procedure. Hat, gloves, mask, gown, everything. Because we want to make sure we keep that peritoneal cavity clean, right? Free from infection. Now, these things are usually, if the baby's home, we do peritoneal dialysis at home. So they come in, the baby mother, the nurse, whoever comes in, sterile garb, hooks up fluid. Now, what does it look like? There's a heater with a bag of fluid, a big bag of fluid, and there's a bunch of tubes, and that fluid is heated. It goes through this little machine and it goes to the baby. So warmed fluid goes into the abdomen. And the nephrologist will order 100 mLs, 200 mLs every hour to be sit there or still for 20 minutes, and then it drains 10 minutes. And they do 8 or 10 cycles a night. Now, how do you measure how much output? Well, usually that little tube is now connected to a Foley bag. So all the fluid in, let's say it was 10 cycles at 100 mLs. That's 1,000 mLs of fluid. What if there was 1,600 mLs of fluid in that bag? There's 600 mLs of urine. And that's how it's done. Now, nursing care of, well, number one, it's sterile, 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 for sure. Okay? Monitoring it for infection is our number one priority. And usually it's that change in fluid color. It could turn white or it could get streaks or get something in it. It doesn't look normal. Number one, call the doctor. And why? It's better to start antibiotics and be sure than to get that peritoneal cavity infected and you can't use it because the child has no other kidney no matter what. Okay. So what best describes acute glomerulonephritis? What is it?
B.
B.
Yes, it is. It's just like rheumatic fever. Okay, so GI. A lot of different stuff here, guys. So nutrition. It's number one, right? We put food in our mouth, our GI system, chews it up, puts with acid, puts enzymes in it, absorbs it, and excretes it. Nutrition, right? We know due to many different reasons, that many different diagnoses, there's going to be problems with absorption of all different things. They mentioned cancer, HIV, sickle cell, cystic fibrosis, low birth weight, but many things can affect nutrition. Now, celiac disease is a condition where the body's small intestine, celiac, don't work right. And it doesn't absorb fat. And it doesn't tolerate wheat, rye, barley, or oat flours. So think about a toddler's meal. Chicken nuggets and macaroni and cheese, right? They all have breading on it. They can't have it unless it has rice flour or potato flour or a different flour on it. But it can't have rice, wheat, barley, or oats on it. Okay. Today we're lucky because there are so many options Go to the grocery store, pay attention. Go to the bakery, look at those that say gluten-free. Pick up a bag of potato chips. It says gluten-free on it today. So it's amazing the evolution, what I've seen in just helping patients continue and maintain being celiac free. I've seen what children look like when there's celiac disease and they eat something they shouldn't. They're bent over, screaming in pain. It hurts. Now, one of the things about celiac disease is steatorrhea. Steatorrhea is because they don't absorb fat. So fat just comes in, you eat it, and it's excreted out. Now, that excrement, that stool is bulky and it stinks beyond high heaven. Probably the worst smelling stool that you will smell. The other thing is because they're not absorbing all the nutrition at the way that they should, they're going to be smaller. They're going to have tiny buttocks. And because of the fat, it causes abdominal distension and a lot of gas. They're going to have all of that. And they're not absorbing fat. So what about all those fat vitamins? Just like cystic fibrosis, right? We have to replace them. Now we have food allergies. At 6 months, we start feeding these infants, right? We give them a new food every 4 to 7 days. Knowing that if they have a food allergy and they have to avoid something, remember that has to be replaced in another way. If they're lactose intolerant, they can't have milk, they still need vitamin D and calcium from somewhere else. So that's something that needs to be, paid attention to. GI dysfunction can cause many things. I mean, if a little infant is constantly vomiting and losing all their calories, they're going to have growth failure. Besides that, cognition delays, right? So it's the spitting up, regurg. Children can be nauseous, vomiting, diarrhea, constipation. Your tummies can hurt. We can have conditions that are dysphagia, dysfunctional swallowing, the George syndrome, Pierre syndrome, Pierre Robin. Both of those are dysphagia, small little chins, problems swallowing that need to be taught by speech therapy how to eat and swallow. And you don't think about this. Fever causes GI dysfunction because the amount of dehydration and fluid loss. So, dehydration, talking about it. We know it's caused by many different things, but we know that dehydration is not good in children, and we need to replace that fluid as soon as possible. First, we got to diagnose it, right? So, 2 great pictures of 2 infants with fontanelles that are sunk down so far. But, it's not just that that's showing me that they're dehydrated. Look at the color of those infants. Look at the ears. They are pale white. That is dehydration. That is a prolonged capillary refill. All right, that's looking at them. Then I pick them up, they cry. I don't see any tears. Probably the saddest thing to see a baby, their little chin is quivering, they're crying, and you don't see any water coming out of their eyes because they're that dehydrated. Then you listen to their heart rate and you go, oh, it's 200. Now, depending on how old that child, depends on how severely dehydrated. Now you know why you have gotten that handout on heart rates. You got to figure a 1-year-old, a heart rate of 200 is really bad, right? A heart rate on a newborn would be 140 to 160. 200 might be a little bit. Could be fever, dehydration, could be just pain and screaming. And then the other thing we see is something called skin tenting. You take their skin and pinch it and it just tents. It's just very classic pediatrics. So what do? Got a kid who is dehydrated, looking that bad. Number one, we'll start an IV and we will also get a basic metabolic profile. That is our baseline electrolytes, looking at sodium and chlorides and glucose and CO2s. We need that as a beginning place to know how much of what we need to do. So we'll give them a bolus of fluid. Remember, very important. You never give a bolus of an IV fluid that has dextrose, and you never give an IV bolus of fluids in fluids that have potassium. And you will not hang an IV with potassium until either you have a potassium level from the lab or the child has urinated. Now I have a question. You see this kid really looking bad, right? You see really dehydrated. You admitted him in the hospital. It's 3 days later. They're ready to go home. How do you know that the treatment that you did for that child worked with dehydration? Well, you're going to check that admission weight versus what it is right now. What's another thing that you can look at? This child will definitely be on intake and output. You're going to see the output start increasing over the input when finally they get caught up in all of their fluids, aren't you? So again, don't just think of what you do, what to look at. Think of how do you know it worked, and more than that, okay? Get the brain starting to think what's going on. So intake output, we can measure many, many different things, okay? I think the biggest telltale sign intake output is always going to be looking at intake output and your daily weights. That really tells me a lot. You can have diarrhea for many different reasons. It could be acute, could be chronic, it could be due to food prep, could be so many things. So management of diarrhea. Now, diarrhea is different than vomiting, and vomiting is a little bit later. But diarrhea, you can eat. You're not vomiting. And diarrhea is just a lot of fluid starting to coming out, right? So we need to replace the fluid. But what if you don't replace food? Now the diarrhea can't get solid because there's nothing in there to do it to. So then the diarrhea is going to continue. So what we'll do is we'll give oral if the child is good enough. You don't need to put IV fluid on a child with diarrhea unless they look like those infants before, looking really dehydrated. But a normal child coming in, has had diarrhea, is still alert, talking with you, oral rehydration with electrolyte solutions, Pedialyte, Gatorade, Powerade, one of those things. And that should be okay. And then increase their diet. Start slowly. Start with crackers and start off with very bland, spicy food, non-spicy foods. The old thing used to be a brat diet. That was the thing that they said. Bananas, rice, applesauce toast. All those things actually work very well. I mean, they don't say to give them in that order anymore, but those are a good starting point. It's just no spice, and of course, keeping the fluids up. Now, constipation. Children can be constipated. It could be due to something, structural, or it could be due to psychological. Now, children, the one thing that I've learned that they can control is their bowels. I've actually seen young 2 and 3-year-old children come into the ER, and the parents tell me they haven't moved their bowel in 10 days. And I'm like, no, that can't be. They go, no, they have not. I've been with them. No, they haven't. I'm like, okay, I believe you. So, of course, what do? We'll do an x-ray. And then the x-ray comes up and the whole colon is lit up in stool. You're like, oh my goodness, this child's just full of it. Why does that happen? It's not structural. It's something that happened. It could be they want attention. It could be their dog died. They had to move, grandma, whatever. Something happened, psychosocial, and it will cause them to stop stooling and then get the attention and then get them moving again. Now, it's the only time I will tell you they will give them an enema. We never, never give routine laxatives or enemas to children. Will increase bulk in their fiber and in their diet, increase fluids, maybe some Miralax, but no laxatives and no enemas on these children. But when they're that packed up, put on a diaper 3 sizes too big because they will fill it up once that enema is in. And my grandson, it happened to him. It was a size 3 diaper. I put him in a size 6. put him on. We gave it to him, and I'm telling you, the whole diaper. He just kept rubbing his belly. He kept hugging me, and it filled up. And boy, did he feel better. It was due to many reasons. So, constipation during newborn period. Now, you've heard me talk about cystic fibrosis, right? What else causes constipation in the newborn period? Hypothyroidism. We learned that last week, right? But we also have Hirschsprung's disease, or then, of course, structural, Etrigia, stenosis. But I'm going to go into Hirschsprung's in a second. So constipation in the infants, we know that breastfed babies stool a lot. That's just normal. Infants on formula fed tend to be more constipated. Why? I don't know. How would we stop that constipation if it's before the 6 months? We might just tell them to have a little bit of apple juice or give them a little bit of prunes. Do it very holistically. We're not going to be giving enemas and all those things. No, very easily. Because remember, once you start on that stuff, you need stronger stuff. Can you imagine by the time you're 60 years old, you need dynamite. So you don't do it now. You keep the baby, which is very natural things. For instance, if they're older, whole grains, black beans, I thought that was interesting because I live in Florida. It's one of those things that adds bulk that can help them. Remember, there's all things. I know cherries work on me, prunes, whatever it is, those are better than the other stuff. So enterobiasis, this is what we call pinworms. Have you noticed today that there's not a lot of sandboxes out there? Years ago, every playground had a sandbox and every kid was always there. No more. And you know why? Because there's pinworms in them. And children get in there and their nails aren't they're not trimmed enough, and they get the dirt and stuff in their hands, like even outside in the grass and playing and whatever, and the eggs go beneath their nails. And then of course everything's in their mouth, including dirty hands. And then these eggs hatch inside, and then they try to crawl out the anus at night. And it creates the worst anal itching and scratching and going on down there. So what we've been said to do is at night, because that's when they come out in the dark, take a piece of Scotch tape, go down to the anus, push it there, get it up, and hopefully you get a little worm. And we can show the doctorate, and we can order a deworming medicine for the family. And of course, the other thing is keep those nails short on the child, because kids are going to go out, they're going to play, they're going to get in the dirt, they're going to eat it. This is what they do. But let's try to decrease the incidence. Now, peptic ulcers, you're thinking children? Yeah. What we do again is treat them more holistically, more diet. Again, usually peptic ulcer is more psychosocial, what's going on, trying to address that. And of course, if we have to do something, it would be more medical. As in medications like Zantac, but today it's not Zantac. They don't like that one anymore. It's called Pepsis or famotidine. And that's the one that we would use instead. And all it does is reduces the gastric acid. And I think it's more in time, and it's more through talking, and it's more calming the child down that can help. Hepatic disorders. We're talking about, hepatitis, liver things. Now, it could be many different things with the liver going on. You could have biliary atresia at birth, where the liver is not connected to the common bile duct. And that will create liver going, bile going into the body and creating jaundice, which looks like hepatitis, right? So how do we treat a child who has issues with their liver? It's not working right, not functioning up to where it should. Well, again, it goes back to nutrition, nutrition, nutrition. What does the liver do, the bile? It digests fat. Here we are again, digesting fat, and a hepatitis child can't digest fat. So again, low fat diet, high protein, high carbohydrates, and again, monitor the vitamins. Biliary atresia, like I just mentioned, one of the things about biliary atresia is, yes, the bile can't go into the body, into the intestines, to the common bile duct, and it goes in the body, and the eyes turn yellow, and the skin, et cetera, et cetera. These children, what you'll see is very pale stools because there's no yellow, no bile stuff in there, okay? And again, they do not absorb fat. So again, we're worried about nutrition. If we don't take care of this child and we don't let that liver get connected and somehow reconnect it to the common bile duct, it will go to cirrhosis, and that will be a liver transplant. Okay, Hirschsprungs. This is the other one that causes constipation at birth. It's also called congenital aganglionic megacolon. Aganglionic, no nerves. That means you have a piece of intestinal tissue. It's alive, full of blood vessels. It's sitting there, but there's no nerves. Well, there's no squeezing peristalsis, is there? There's nothing. It sits. So stuff goes down the mouth, into the body, down into the colon, and it sits there. And now you would have a stool, right? There's no peristalsis. It can't get there. Sometimes that little thing, that rectum, that little squirt button on the bottom, it looks like a little frosting thing that you would do a cake with, and a little ribbon stools might come out. That little rectum on the bottom, maybe, but maybe not. What are you going to see? No stool, 24 to 36 hours. How do you diagnose this? X-ray, and then we got to determine, is this a real Hirschsprung's? We're going to do a biopsy. We're going to see, are there nerves in that tissue? And if there's not, guess what? We're going to go in and remove that piece of intestines and either pull it back until what's left in there, or we have to pull it up, put a colostomy, and hopefully we'll close it up after 1 year, before 1 year's old, before potty training, okay? Now, another thing, do you see this? 4 Downs babies. Again, this is something else they're more apt. So congenital heart defect, leukemia, hypothyroidism, and now Hirschsprung's. Poor children, huh? One of the things they call that, taking the piece of the intestines out and reconnect it, they call that the pull through, because they pull the one up and push it on the bottom, and now they're connected, okay? That's what that means. Now, appendicitis, you've studied it in the adult world. Same thing you're going to see in children. No difference. It is right lower quadrant, Burney point, rebound, tenderness, all that good stuff. If pain disappears, yes, the appendix has burst. Now, children, I tell you, I can spot these children walking down, going to their room, if they're walking. Mother is holding them with their left arm. Their right hand is down on their lower inguinal area, and they're bent over and they're limping on the right side. And you're going, oh, that's an appendix. It is so classic, so clear. So what do we do? Number one, NPO. Don't have anything more to eat or drink, because we know this child's going to the OR. And food can slow it down a little bit, if depending on anesthesia. So we need to get an IV in. And because this is an itis, it's an inflammation, it's an infection, we're going to give pre-op antibiotics. We're going to prevent any infection from getting in there or becoming so that they can't treat it. And then, of course, any pre-op meds that they have, yes, they'll take. All right, you didn't get to the OR quick enough, and now the appendix burst. Now you had peritonitis. So they go to the OR, they open them up, and they clean them and wash them and take out whatever they have to, and they send them back to you. This child has the most angry abdomen on planet Earth. All of that intestinal appendix burst, all of that, debris, caustic infection, nasty stuff. all over, and it's taking those intestines, and the intestines are angry, angry, angry. So we need to rest intestines. How do we do that? Number one, you can see the NG tube. Why an NG tube? It takes care of the gastric acid. It can't go into the intestines, and it can't upset the intestines that need to rest. Two, NPO, nothing by mouth at all. Now, priority, priority. You've had a ruptured appendix and infection is everywhere in this child. Priority is your IV antibiotics. Second of all is to get that child up out of bed and prevent pre-op complications, post-op complications. How do we do that? Well, child's NPO on IV fluids, getting his antibiotics. Now, this child needs to do that coughing and deep breathing, and ambulating is great. We want to get those intestines eventually start working. So make sure, and this child won't ask, it's your responsibility as a pediatric nurse. Let's give them something for pain before we start coughing, deep breathing, and getting them out of bed and ambulating, just like you would do for an adult. Kid won't ask, okay? And you got your NG tube. And then the other thing is that wound is from an abdomen that had burst caustic material in there, and we've closed the edges. It's dirty edges closed. What does that mean? That means that we have to be careful of dehiscence. And it will, because they're dirty. They're not strong, healthy tissue that closed. So monitor that wound. It can dehisce. And as I said, good pulmonary care, and kids, the funnest thing is you can have fun with it. I have done things like blowing bubbles, pinwheels. I've actually done spitballs with a straw and put up a target for an older kid that had really bad lungs, and we would see who would win at night. I worked night shifts, so it was easier for me to do these things. And I'm telling you that girl's pulmonary status, they were amazed how well she did because of my spitballs every night. And they heard about my spitballs and they loved it, and it worked. And it worked. That was the thing. It was nothing that could hurt her, and it worked. And of course, out of bed, ambulate, and all that good stuff for post-op. Omphalocele, anything born outside of the belly. We've heard extrophy of the bladder already. We're going to hear it again, but omphalocele, this is a piece of something, organ, liver, or something. We're going to see a gastroschisis too, a stomach out of the belly. What happens is the midline of the abdomen closes, and that intestines, that abdomen, that stomach, that liver didn't get inside quick enough. So it closed, and that stuff is hanging out. At birth, what is our concern? We usually know about these. So there's usually a C-section, usually a big team on hand. Our biggest concern is keeping that, again, that blob from the inside of the belly sterile and moist. Again, nice, sterile, wet, normal saline dressing. Get them on a warmer, keep them warm. You can't cuddle these children. You can't put them in a blanket. You need to be able to watch them. And again, antibiotics, prevention of infections, and of course, IV fluids they cannot eat. Now, intussusception. Intussusception is something that happens. I want to tell you, it's that 2-3-year-old kid that I always see with it. The youngest I've ever seen was 5 months, but I heard it goes to 3. What it is a sudden onset of the intestines suck into each other. And this child, there's nerve endings on the end of these intestines. And when it sucks in, it swells and it creates intense abdominal pain. It also forces a little secretion out the anus, and it might look like currant jelly with a little bit of blood in it. So, little 2-year-old comes in, mom's holding him, and she's like, the kid is going crazy, knees up. I mean, jerking like, hurt, right? I will get the child, and I can look in their diaper, and I can see that little current. I know they're intussusception. So how do we treat this? The interesting part is most of them will just automatically come back by themselves. and you don't need to do anything. Occasionally, we do an ultrasound and we find them already still in there. They're stuck together and they're not coming out. Well, this one we need to send to radiology, to a radiologist, and they either do a barium enema or an air enema, and they, under fluoroscopy, they stick a tube up their anus and they fill it with barium or air and it pops open this intussusception. So no surgery is needed. Now, I've seen one where they had to take out a piece of intestines on it. We couldn't, no matter what we did, get it extended. It was too far gone. It was really tucked together. Most children that just, responds by themselves and it comes out, we'll just tell them to increase the diet, their fiber in their diet. That's all we do. So it's ultrasound, and I told you how we fix it. Mecca-diverticulum. The small intestine, there's sometimes what happens is called a remnant of a fetal mesenteric duct. It's this tab, this outpatching in the small intestines. And inside that is a big blood vessel. Because remember, intestines, you're absorbing all of the food and water and everything. So there's blood vessels there. Well, it rips for some reason. Food did it or whatever. Peristalsis, it rips. And that blood vessel just oozes blood, oozes blood. Symptoms: painless rectal bleeding, bright red blood. You look to see if it's maybe a hemorrhoid. No. And then, maybe they might do, look, in the rectum, and they don't see where it's coming from. They're probably going to have to do this radionuclide test. And the way that they determine is they rule out, number one, the obvious, which is the hemorrhoids or something in the rectum. And then they do this test and they send them to the OR. And all they do is take it out, and these children do fine. And they're fine for the rest of it. It's just trying to diagnose them. Where's this bleeding come from? IBS, mouth to anus, either colitis or Crohn's. How do we treat it? Diet, steroids, surgery. And our biggest thing is nutrition. Nutrition. Ulcerative colitis, one of the big things that we see with it is profuse diarrhea. And with profuse diarrhea, you're losing a lot of nutrition. So it is trying to prevent those things. Today they have steroids they give them. They also, many of them give them those DMARDs like Humira. You've heard of those for like rheumatoid arthritis. We use it for ulcerative colitis too. And it does help stop the body from attacking itself, basically. Now, Bell syndrome. Bell syndrome is where, for some reason, a piece of bowel had to be removed, and what's left is really not enough to absorb all the nutrients the child needs. That's basically it. It could be due to a necrotizing enterocolitis. Necrotizing enterocolitis is your newborn, and it's your intestines, and it dies, and you have to take that piece out. What happens, and this is my belief in what this is, NEC, it's premature newborn infants. I believe that there possibly was a hypoxic episode during delivery or shortly thereafter, and the intestines lacked oxygen. And then you fed them, and the intestine says, I don't like it, and it dies. And that's what happens. It's the feeding, even small amounts, that create the intestines to die. And actually what we see is the stomach start looping, you start seeing aspirates coming up. So we know something's going on, and we do x-rays and we find it. And we found this on this one girl. Her name was Jessica. She was a cardiac child, and she was in for her second stage surgery, Glenn, really bad hypoplastic child. And all of a sudden her belly blew up. So finally we went to surgery, and it was her small intestines. And I think the number was 58 centimeters. I don't even remember the number. It was like this much is left out of like, how many miles of intestines in there. So that meant she wasn't absorbing anything. So that child went home post-operatively, She had it just like this little boy, Broviac, hyperal lipids at night for nutrition, and that little tube was your GT tube feedings during the day, supplement, and she would even take oral. So necrotizing enterocolitis causing short bowel syndrome, and it's all about nutrition. As I said, gastroschisis, again, it's just like omphalocele, same thing. Same, that's what we do for that. Children can have hernias. The worst one is a diaphragmatic hernia. It's usually at birth. Diaphragm doesn't fully function, and the intestines go up into the left side of the chest. So you only have one lung, and it's pushed over by the intestines. Extremely ill child. The other type of ones that we see all the time are things like umbilical hernias, inguinal hernias. I like the belly button ones. I like sticking my fingers in and out when they're soft and they're squishy and the kids think it's tickly. The problem is when you try to push on that little out protrusion there and it's hard, hot, and painful. That means it's incarcerated or strangulated. It's pinched. The blood supply is gone. The intestines is going to die. What do we need to do? We need to get them to the OR now. Now, anorectal malformations. What about an imperforated anus? A baby without an anus. Did you ever think that was possible? Well, there's the picture. I've never seen one. And it says no rectal temperatures because there's no rectum. Biggest thing with that one, you're going to have to put a colostomy in right away because there is no where's this going to go? There's nowhere. There's no outshoot, right? No exit. As I said, fistulas that they always come. It's nursing that we do look for them as we are, changing diapers and seeing if urine coming out the right place or stool out of the wrong place. It does happen, and I've actually found it myself. Now, ingestion of injurious agents. Well, kids put everything in their mouth. They eat everything. Biggest one is actually their vitamins or Tylenol. That's the bad one. The vitamins, as long as there's no iron, it's just what you don't need will be excreted. I've seen them take mommy's heart pill. I've seen them eat rat poison. Of course, the Tide balls, we've seen that one. And then I've seen them eat Tylenol, and of course, the vitamins. And what do we do? What is you think we need to teach parents for home? So your kid has done something, eaten something they shouldn't. Number one, call poison control. Number one, call poison control. Poison control has the most up-to-date information and could tell you, do you need to give milk to make sure it doesn't work as well? We never say vomit anymore. We don't give Epicac anymore. We don't want them aspirating this stuff. Okay, so best thing is call 911, call the poison control and get in the car and go. They do something. So we had diarrhea. Here's our vomiting. Now, vomiting is when you can't hold anything down. It could be due to many different reasons. How do we treat vomiting? Well, if they're vomiting, you have to put in an IV. And how do you monitor where they are on the dehydration scale? A metabolic profile. So, metabolic profile, start an IV, give a bolus of fluids, no potassium, no dextrose, keep them MPO. Give them some antiemetic, wait, and then you might be able to start a little bit PO. Reflux, GERD. We see this a lot in infants. It's that spit up, that all that extra calories just going away, right? Problem with the GERD and infants is that they're losing their nutrition. So the way that we do infants to hold their food is we'll just say, put a little bit of rice cereal in, let's say they're having a bottle. It's 5 mL, that's all it is, of rice cereal, a teaspoon in an ounce of formula breast milk. And that thickens it. And that holds the milk down so they get their nutrition. That's the first thing that we will do. We're not going to put them on any meds or anything like that yet. We'll also teach parents to overfeed, how to burp, how to have them sitting up when they're done eating. It could be as simple as they're not burping them well enough. So again, you can't just run to treatment. What happened, right? One of the things we see with older children, they're coughing a lot and they're complaining of burning in their chest. This could be reflux, okay? How do we treat reflux in older children? Or how do we treat reflux in those children that are resistant to everything we've tried and now your esophagus is burning? It's getting serious, right? What they'll do is initially, older children, of course, it's diet, no overeating. But if that's still going on, they might be considered for a Nissan fundoplication. Now, if you've ever seen anybody, any age, get a gastrostomy tube, most of them have a Nissan fundoplication with it. And the reason is it pushes the stomach up so that you can't vomit. It looks like that picture. You can't vomit. So why would we give this to reflux? It can't go up their esophagus. It keeps the food down. Now, hypertrophic pyloric stenosis. 3 months, 3 weeks, 3 weeks to 3 months, right around that age. Young babies. And one of the questions I ask every young infant that comes in that I've seen, and they're telling me they vomit, I ask them, is it dribbling or is it across the room? If it's dribbling, it's reflux. That's good. If it's across the room, it's pyloric stenosis. In the stomach, there's a valve called the pyloric valve that empties into the intestines. It becomes thickened and hardened and muscular, and milk can't go down. If it can't go down, it'll come up. One of the things when they tell me it's across the room and it's vomiting like that, I'll take my hand and put it underneath their xiphoid process. And little right to the middle, a little bit to the right, maybe, you might feel like an olive. I call it a marble. Same thing. This little round. That is the pyloric valve. It's that thickened, you can actually feel it. You know that is pyloric stenosis. Now, we'll send them to ultrasound. They'll confirm the diagnosis. And because these are young infants, NPO and start IV fluids. We don't want them to get too dehydrated. And these children do well post-operatively. We start clear liquids and they're home in a day or two. And they usually, there's no, forward problems in the future. Cleft lip, cleft palate, big problems with eating, right? Cleft lip is usually closed about 2 to 3 months. It could be one side, both sides, and it could include the palate. And cleft lip will close at 2 to 3 months. The palate, that's the upper part of your mouth, usually about 6 to 12 months. We will make sure we repair that. We want to get it done before they really start talking because it does affect their speech so much. Big issue with cleft lip, cleft palate is feeding. They can't eat well. They can't perform a suck. Breastfeeding is mother has to squeeze her breasts to make sure the milk goes in. And then a mother actually made these bottles many years ago. And that stuff that sticks up is very soft and the milk goes into it. And slowly you hold the chin and you squeeze slowly. And they do get that feeling like they're sucking and they are getting their milk. Another thing at birth, this would be a baby born. And many times you don't know this is going to be happening because this is no connection from the esophagus to the stomach and another connection that shouldn't be there between the esophagus and the trachea. And anything that goes down the mouth goes right into the lungs. This child at birth, usually right after birth, we clean their mouth up, suction them, send them to the nursery, and sometimes they give them a little bit of sugar water to make sure their blood sugars don't drop. This child's going to gag and cough and choke because that's going to go directly into their lungs. And that's the telltale sign. How do we treat these children? Well, either or, whether it's atresia or the fistula, they both need surgical intervention. So before they get there, nothing by mouth, nothing, okay? Suction at the bedside, elevate the head of the bed. And these children, they can't eat. IV fluids, and because they're still swallowing their own spit, it's still going and mini aspirating in their lungs. You're going to put them on antibiotics to prevent that aspiration pneumonia. And then when they're ready, they go to surgery, they repair it. These children are normal. Everything else is just these weren't connected. Any questions? A lot of different things, isn't it? You never thought of these weird things these kids can have. Anybody want to win the Cahoots today? Nobody has a desire? Come on, Jessica, you do. I know you do. All right, let's just get going. I want to get you out at a decent time tonight. There's a lot of questions. So I'm going to push through them pretty quick, guys. Okay. I want to give you what you need. All of the following are symptoms of dehydration in an infant. Basic concept, something you should be aware of. I mean, I could go on and on and on about signs and symptoms: heart rate, blood pressure, crying with no tears, a sunken fontanelle, no urine output, tenting. I could do all of these things. And yes, the one thing, no, it's a decreased urine output. What is priority treatment for a child with dehydration due to profuse vomiting? I do several questions on vomiting and diarrhea, so I want you to know the concept. If you're vomiting, you cannot feed them oral. Diarrhea doesn't mean you can't feed them oral because they're not vomiting. So, dehydration, vomiting, we're going to give IV fluids. Now, will we be making them NPO? Yes, we need the IV fluids because we don't want them to be dehydrated. That's why that's priority. What is the treatment for an infant with diarrhea lasting for 4 days? So I've got all of the answers down here, right? Do we feed them or do we give them fluids? And the answer is diarrhea. We're going to give them Pedialyte. Now, if this said diarrhea, lethargic, pale, heart rate, whatever is elevated, but just diarrhea. The point of this one is, yeah, they both could be right. I'm not going to argue with it. But diarrhea, number one, you start with PO. If they're not alert, yes, it would be IV. It's one of those assessment skills there. What acid-base imbalance may you see with a child that's having profuse diarrhea? Now, diarrhea, stool, has all your digestive enzymes, and those are all alkaline. So alkaline is going away like crazy. So I say, so what is left? And the answer is metabolic acidosis. Now, for those of you who picked alkalosis, when you're vomiting, what are you vomiting? You're vomiting gastric acid. So you're losing acid. What is left? Alkalosis. Okay. I hope that can help you with those two acid-base equations right there. They are on the HESI. You will see that again. Multi. An infant has not passed meconium stool in the first 24 to 36 hours. What are you going to assess for? So it doesn't matter electrolyte imbalance. That's why I put it there. You know, hypothyroidism, cystic fibrosis, Hirschsprung's disease, any sort of structural atresia stenosis, yes. Electrolyte, no. A deficiency of vitamin D. So remember all about those nutritional things. Vitamin C is scurvy, right? Vitamin D does what? Vitamin D works on bones, and that's what you have to remember. Vitamin D bones, what would happen with bones? And it's rickets. And rickets are part of a bones are irregularly disformed. This osteodystrophy, that's it. And the bones get weird because the vitamin isn't what it needs, and that is rickets. Nutritional deficiency. Multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? Hmm. Unable to eat or drink anything. That was the difference. We're going to be doing that basic metabolic profile. I want baseline. I want to know what's going on. And then I'm going to start IV fluids. I'm not messing with anything oral until we get that tummy settled down. Multi. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So we've got got a peritoneal cavity that's full of this appendix that just burst in there. So we want them out of bed and walking. So no, we don't want any post-op complications. So it's going to be not complete bed rest. Angiosuction, yes, we want to keep the intestines free from irritation, that gastric acid into those intestines. IV antibiotics, and remember that surgical site was two dirty wounds and things that put together, and it could dehisce. Always assess it. It's going to be a test question. You should be aware. Passage of urine, usually at night. Who should have voluntary bladder control? Many kids never are potty trained, always are urinating their bed at night. And then there's some that occasionally, oops, once a year. And it's called enuresis. Now, with passage of urine at night, enuresis, remember, if it's starting new, it needs to be reviewed and looked at. It could be diabetes insipidus, right? Diabetes mellitus. But if it's always going on, then you know what's happening. Multi. What is Hirschsprung's disease? So Hirschsprung's disease is no nerves in the colon, and it causes a megacolon. It's, there's intestinal obstruction called a megacolon, and it's because it can't squeeze because there's no nerves. Multi. When teaching parents about Hirschsprung's disease, the nurse would include what? How are you going to treat it? So Hirschsprung's disease, we have to take out that intestines that doesn't work. dead, it's alive, but it's not functional. So it causes a bowel obstruction. We have to later on monitor those bowel habits. And it's a two-stage surgery, or that pull through can also be done. And as I said, never, 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 never laxatives or enemas. What types of stool would an infant with Hirschsprung's disease have? So it's that ribbon shape. Remember that big open bowel, and it comes this tiny little anus. It's like a little frosting applicator for a cake, okay? Ribbon shape. That's what it looks like. Which is a condition that occurs mainly in children when the intestines telescope into itself. It'll either resolve by itself and will increase fiber, or they might need to go to radiology or an enema, a barium enema, or they might need surgery. It is called an intussusception. Severe pain. Multi. A 2-month-old with GERD has been treated by thickening the formula. How do you know it's working? The questions like this is not only having a diagnosis, knowing how to treat it, did it work? And the answer is they're not going to be spitting up anymore. So, less regurgitation, appropriate weight gain, and then cognitively they're going to be where they need to be, right? Because that's all part of it. How can you decrease the incidence of enterobiasis in children? Enterobiasis is those tiny little worms. Again, it's just fingernails being short. Can't keep the fingers out of their mouths. What are signs and symptoms of enterobiasis? You know, the one thing that children always do, it's hands and mouth, always, it's that their comfort. It's their stress reliever, right? Explore the world in their mouths. And it's intense rectal itching. And it's to the point where you know your kid is itching, and you go looking for it. Third, gastroesophageal reflux disease. What is that? And that's when the stomach, you eat fine, and all of a sudden it starts refluxing. And remember, it can burn the esophagus, can go into the stomach and create a lot of problems. And it could be that spit up, losing calories. What would the nurse be looking for when a patient has meccal diverticulum? That's that small intestine, that little tab that rips. And it's what we call painless rectal bleeding. Small intestines, the tab has a big blood vessel and it rips and it just starts to bleed, bleed, bleed. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment's priority? To know about this child. You know, as working in the ER like I did for many years, is you have to place this child in the proper bed in the ER. Are they urgent, or are they something that just needs to see a doctor? And understanding these children, where is the abdominal pain? Is it an appendix, or is it just a GI type thing going on? Very important. Where is it? What would the nurse expect to see in an infant with biliary atresia? That means the biliary duct does not connect to the common bile duct, and bile just goes into the body, into the baby. And remember, the liver is bile, it digests fat, okay? So when we have stools, there's not no bile in it because it doesn't get there. So it's going to be clay colored. So it doesn't color it. Also, no digestion of fat, no fat digestion, any diagnosis, abdominal distension. Fat causes gas. What structure of the mouth can be impacted by cleft lip palate? A little bit of anything? Answer a little bit of everything, isn't it? Mouth, lip, everything. Cleft lip repair is typically done when? Now remember, the first thing is everything is the mouth, exploring the world in their mouth. They've got to get that lip fixed pretty quick so that we can at least attempt to suck and explore the world, right? It's 2 to 3 months that we do the lip first. Lip is always first. When does the cleft palate repair typically occur? So we did the lip, 2 to 3 months. And I love this picture, and it shows you kids can actually look pretty good. 6 to 12 months. And the answer is before they really start talking, okay? Everything we do, like even things that we do, it's before potty training. It's before they start talking. We try to before a year old. Many of these, that's your answer. Esophageal atresia. What's that? And that's when the esophagus does not go to the stomach. There is no connection at all. So it goes down, it fills up, then it goes up, and it goes into maybe a the fistula is there. Sometimes it's both together, and it could go in there. Sometimes one, sometimes both. What are the classic signs of esophageal atresia and tracheal esophageal fistula? What did I tell you at birth a nurse might see? And it's usually when we start to try to give them that first little bit of dextrose water when they're in that nursery, just being checked out right after birth. And it's when you see these children, they're gagging and choking and coughing because that fluid's going right down into their lungs. Sigh. Neonate with suspected tracheoesophageal fistula nursing care should include remember, tracheoesophageal fistula, fluid goes down the esophagus and into the lungs. So we're always concerned with this one is about those mini aspirations. Elevate the head of the bed, IV antibiotics, and IV fluids. This child will not be fed. Think about it. There's a connection between the esophagus and the trachea. You drink, it goes across the fistula into the lungs. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? What is ranitidine used for in a child with peptic ulcer disease? Ranitidine or famotidine, which is Pepcid today. And that's just all it does is decreases the amount of acid production. That's all these things do, okay? Signs and symptom of a hypertrophic pyloric stenosis. So remember, pyloric stenosis is a young 3-week to 3-month-old little infant, and they are explosive across the room, vomiting. So if they're telling you they're doing that, you put your hand down at their xiphoid process and you can actually feel this little round thing. Now, they're hungry. They're not poor appetite. They eat, goes down, sits there, and all of a sudden it can't go down lower. Poof, comes right out forcefully. Signs and symptoms of hypertrophic pyloric stenosis. So it's basically just projectile vomiting. As I said, they have an appetite. I have a question for you all. Do you want to keep going? Or it is 10 after? Is when I told you I would end today's class. What would you like to do?
Go to bed.
Anybody else?
What was that? What'd you say?
What I said was, I told you at 10 after, I will let you go today because we had no break. We're
Oh,
not
yeah.
done with the cahoots. You can continue it, or we can stop right now on slide 30.
Stop right
Mhm.
now.
Stop now and post the link to it and we could practice it later.
Okay, there you go.
Thank you,
Whatever
Dr.
you all
Bogart.
want. I know
Thank
what
you.
it's like to be a student. I know what it's like to be tired. And I know when you didn't have an earlier break that, I do still have to give you a break. And I know that working all the what you're doing and then coming to school and then you'd rather get off early so you have tomorrow. So anyway, I get it. Any questions for anybody?